Yeah, many thanks for the invitation for this virtual meeting of the long traditional Paris hepatitis meeting. Dear Mark, dear Crane, you asked the question of elimination of HCV by 2030, whether it's realistic in Western Europe. And the key slide to show for this question is this full analysis by Homi Razavi, who actually analyzes more than 45 countries currently. And you see that there are just 11 of 45 high-income countries currently on track to meet the HCV elimination targets. It's good to see that a number of Western European countries are within the 11 countries, and it's nice to see that compared to the last analysis in 2017, there's Sweden and Germany and Canada who came from not meeting the targets now down to the possibility of meeting the targets. So we have a lot of Western European countries which are on track, but sadly we have 28 out of 45 high-income countries, including some countries from Western Europe, which are off track for the WHO aims in 2030. So just a few basic comments. What is important? What are the requirements for elimination? It's of course epidemiology, it's screening, it's diagnosis, and most important, linking patients into care and treatment. But also we should not forget about the necessity of prevention of transmission. We're all familiar with that, and the collaboration between all stakeholders. First question is always screening. We had a lot of screening ideas, but there is no way to get out of screening of the general population. Any other risk-based screening approaches or age-based screening approaches have failed and will not work. So we really have to think of general population screening, have to integrate it into other preemptive measures we have installed in our healthcare system, such as then HCV screening at patients coming for preventive colonoscopy or other means of preemptive investigations for women and men, and have to test everybody possible for anti-HCV. We also have to do much better efforts in identifying patients with poor linkage of care. The patient populations are well known. It's a PVID population, patients with mental illness, uninsured patients, people in prison, other populations you see here on this screen. And I'd just like to add a few data here from Germany on the prevalence of such subpopulations. You can see here studies for incarcerated patients, PVID patients, people who have ever used heroin, opioid-dependent patients, foreign-born patients, or HIV-positive patients. Overall, the HCV prevalence rate in these populations is quite high, as is the viremic rate, and they accumulate to a population here, depending on what populations you look at, to a 5-digit number. So overall, this is a population of at least 150 to 200,000 HCV-infected patients in Germany who are hard to diagnose and even harder to provide a linkage to care. And I also like to add a second data set from Germany, which is the migration data, where we have updated data from 2019. And you see here the large list of patients who migrated to Germany. You see here the prevalence of these populations for hepatitis C, and you can envision that this is also accounting for a substantial proportion of patients which have hepatitis C and issues of appropriate linkage of care and treatment. So in summary, acute hepatitis C is declining. We have still issues in Western Europe with men who have sex with men because we have reinfections here. Linkage to care requires major efforts. Personal contacts appears to be superior to other types of contacts. Screening, of course, the PVID population is currently still too low. Antiviral therapy is also not sufficient. We repeatedly notice a gender disproportion in the PVID population, especially women are less likely to be diagnosed and treated. That needs to be approached. We have concerns about adherence, but this should never be a deterrent to treatment initiation. Patients with substance and psychiatric disorders may be clearly treated and achieve very high SVR rates despite multiple medications for their underlying disease. Treatment in prisons is crucial and will substantially contribute to HCV elimination. Resistance to modern DNA therapy is very low and can be managed by second and third line therapies. No issue nowadays anymore. Continuous monitoring of HCV prevalence and therapies is important to track WHO's aims for HCV elimination. But sadly, we have still a large number of even high income countries who are still not on track to meet 2030 HCV elimination targets. There are some Western European countries which are able to achieve, but not all of them. And what is new and definitely needs to be considered much stronger is the combination of anti-COVID testing strategies with HBs antigen and anti-HCV screening, because that's really a kind of general population screening which may eventually lead to a higher diagnosis and treatment rate. Many thanks.